We see it in our patients every day, older adults losing their ability to drive safely. As one ages, the risk of injury or death from a crash increases. I'm Dr. Linda Hill with the UC San Diego School of Medicine. As clinicians, older adults and their families depend on us to identify risk factors that impact driving and assist with the transition into driving retirement. The National Highway Traffic Safety Administration and the American Geriatric Society recommend a series of tests to screen for age-related driving impairments. These tests help you assess competency in 3 areas: vision, strength, and cognition.
While there is no specific time to start looking for driving impairment, there are some general indicators. Around age 65, a baseline screening should be considered, unless medical reasons exist which may warrant screening sooner. Patients may self-disclose driving concerns, or a family member might mention it. Has your patient recently been diagnosed with a new condition, such as a loss of consciousness, myocardial infarction, a stroke, or cancer? Other medical conditions may not be immediately obvious, but will affect driving ability. If a patient is taking 3 or more drugs, or even just one of certain classes of drugs, a screening is recommended. Screening should be repeated as necessary based on clinical concerns. These assessments can be performed in any order, and most can be performed by a medical assistant or other allied health professionals, such as occupational therapists, leaving the interpretation and management to the clinician. You can find a pocket guide to these tests on our TREDS website under Health Professionals. Patients who refuse to take these tests should be failed and referred to specialists or the DMV as indicated. 90% of the sensory input needed for driving is visual. 2 tests are recommended and can be given in any order. The first test is for visual acuity using a Snellen eye chart and can be performed by a medical assistant. If a patient's results are 20/50 or worse with their glasses, refer them to an eye specialist to see if their vision can be improved. The visual field test measures the scope of a patient's vision, including their peripheral vision. As the results are open to interpretation, this test should be performed by the clinician. Failing this test may indicate an underlying potentially treatable disease, such as glaucoma. The next series of tests look at strength and motor skills. The first test, range of motion, is required for every screening and is best performed as part of a clinician's routine physical exam. Range of motion evaluation should include neck rotation, shoulder and elbow flexion, finger curl, ankle and foot flexion. If treatable conditions are identified, they should be addressed. Treatment may include medications or physical therapy. If the conditions are not treatable or the patient is unable to complete the tasks, a behind-the-wheel assessment may be appropriate. For endurance and sensory function, choose at least one of the following 2 options. The choice may be based on available clinical resources or individual preference. The rapid pace walk has the patient walk from one point to another point 10 feet away and walk back. If it takes more than 9 seconds, further evaluation could rule out a reversible cause. The Get Up and Go test requires clinical interpretation, and it is recommended that a clinician perform the test. Starting from a seated position, the patient walks approximately 10 feet, turns around, walks back, and sits down. How normally the patient is able to do this is open to expert evaluation and progresses from normal to severely abnormal. If a patient has issues completing the rapid pace walk or the Get Up and Go test in a satisfactory manner, and the cause is not reversible or treatable, referral to an occupational therapist or driving rehabilitation specialist is appropriate. The final series of tests will screen for dementia. While many cognitive assessments are available, these options were selected due to ease of administration and minimal resources required. The choice of which tests to use is based on clinical judgment. All 4 tests can easily be administered by a medical assistant. The Maze test is a recommended component of every screening. After a simple practice test, the patient is administered a different, more complex maze, and timing is kept. Both the time to complete the maze and the total number of errors made are recorded. If the patient takes longer than is allowed or has greater than 1 error, they may require further cognitive assessment. To complete the cognition testing series, you can choose to perform the Montreal Cognitive Assessment, the MoCA, or both a comprehensive trail making and a clock drawing test. The MoCA measures a variety of cognitive and visuospatial skills and includes an abbreviated trail making test and the clock drawing test. This 10-minute test is available in multiple languages, and the score is adjusted for the patient's years of formal education. A score of 26 or higher indicates a low risk for dementia. If a patient scores 25 or lower, look for reversible causes. Treat the patient accordingly and repeat the test. Scores of 18 or less indicate an immediate driving concern. The trail making test, a longer version than the one in the MoCA, and the clock drawing test are easy and quick to administer. Trail making B assesses the patient's ability to make logical connections from one item to another. 3 practice tests are recommended before the actual assessment to improve validity and reliability. For the trail making B test, the patient will connect, in alternating order, the numbers 1 through 13 and the letters A through L. Time is kept from start to finish. If a mistake is made, have them go back to the last correct step and restart from there. Remind them of the rules, but do not stop the clock. Interpretation is simple. A time of greater than 180 seconds represents a failure. The clock drawing test simply has the patient draw a clock on a piece of paper, as a child would, and set the time to 10 minutes past 11. The results should show all 12 hours in correct order and approximately evenly spaced around the clock and from the edge of the circle. Both clock hands should be present, with one hand pointed to the 2. Should a patient fail any of these tests, look for reversible causes and repeat the tests. Consider a referral to a neurologist. If no reversible cause can be found, these patients are considered unsafe to drive and should be reported to the DMV.
These tests can help you identify when your older patients begin to lose their ability to drive safely. As with any testing, it is important to enter the results into the patient's chart, especially if you've counseled them to stop driving. If you're still unsure about a patient's abilities, occupational therapists and driving rehabilitation specialists can help assess driving skills and make recommendations on whether a patient can continue to drive safely. As older drivers begin to outlive their driving ability, they and their families depend on us to assist with the transition to driving retirement.